Today, as we continue our discussion about chronic kidney disease, we'll be focusing on screening for CKD to get actionable information that will help your patients. We'll start with a few cases. Martha is a 61-year-old female here for routine follow-up for diabetes and hypertension. She's been stable on metformin and lisinopril. Last year, her A1C was 7.2, and on her BMP, her eGFR was over 60. Jason is a 55-year-old male here for hypertension follow-up. He's been well controlled on amlodipine, and on his chemistry panel as well last year, the eGFR was measured at over 60. Thinking about these two patients, what labs might you order to screen for CKD? Early in my training, there was a strong focus on getting that albumin to creatinine ratio for our patients with type 2 diabetes, but really, screening for CKD and being more purposeful about it applies to many different populations. In fact, in the 2024 KDIGO guidelines, they're recommending screening for CKD among patients with hypertension, diabetes, established ASCVD, history of AKI, and many other conditions that are outlined in the guidelines. There's not necessarily a defined frequency for how often I measure for CKD. In my personal practice, I'm doing it annually because they're frequently on other medications or there's another indication to get those labs anyways. But once you've established that they have CKD, you want to get those labs annually, and in the next video we'll talk more about monitoring once we've established the diagnosis, because sometimes you want to get them more frequently. Even though we're classically thinking about eGFR so often, albuminuria is really important to keep in mind because it's a risk factor of future complications. Simply put, as albuminuria goes up, the chance of future events like MI, all-cause mortality, AFib, and whatnot also go up. There's some great tables in the guidelines that lay this information out really clearly. When we talk about getting the albumin to creatinine ratio, ideally we get a first morning void sample, and some guidelines recommend repeating it with a first morning void if it was in the intermediate range with a random sample. I like the KDIGO guidelines because they also give guidance for resource-limited settings. Ideally, we're getting the albumin to creatinine ratio, which quantifies the level of albumin to creatinine so that we can trend it over time. But obviously not everybody has this, and so they give in descending order different options that you can consider. If you don't have access to the albumin to creatinine ratio specifically, you could consider a protein to creatinine ratio, or if you have to, you can use the reagent strip with either an automated reading or as the lowest level of accuracy, the manual reading. So if we go back to our two patients, Martha with a history of diabetes and hypertension, and Jason with a history of hypertension, we're probably going to want to get that regular chemistry panel to get the eGFR based on creatinine and an ACR every year. For these two patients, they come back normal. Martha has an eGFR of 72 and an ACR of 15. Jason has an eGFR of 68 and an ACR of 12. So we'll keep on repeating these every year, more frequently if they do develop CKD. You remember from previous videos where I mentioned cystatin C, which can give us some more precision when we're calculating the eGFR. Remember, screening for CKD is important because it gives us actionable information. There's always variation when we get the eGFR, maybe up to 14 to 20%, and getting the eGFR with cystatin C combined with creatinine will give us some more precision to get us that actionable information. I'll give the example of the 70-year-old female recently diagnosed with CKD G3BA2, secondary to diabetes. Her previous eGFR with the creatinine was 42 about 6 months ago. And at that point, she actually ran out of her metformin, and so when she's back for follow-up today, the decision is can we restart it or not? You'll remember there's a black box warning for metformin that we don't start it when the eGFR is below 45, and we should stop it when the eGFR drops below 30. But with so much variation, is it really inappropriate to start the metformin? That's where cystatin C can come in. And so if we recalculate her labs today, we get an eGFR based on creatinine of 45, and the eGFR with cystatin C is 42. Because of her established albuminuria, treating her diabetes as best we can is really important, and metformin is so fundamental to diabetes that we need to be sure if we can't start metformin. So this is a really gray area where it's important to engage the patient in shared decision making, and you might consider using a lower dose of metformin if you are worried about lactic acidosis. So to summarize, be really purposeful about screening for CKD, getting both the eGFR and the albumin to creatinine ratio when you have access to that test, otherwise the other ones that we talked about. Make sure you're doing this annually in the groups that qualify, such as hypertension, diabetes, ASCVD, and history of AKI. Once you've made the diagnosis of CKD, you're probably going to want to increase screening frequency, and we'll talk more about management and monitoring in the next videos.